as it is in most non-unions. And the clinical signs, of course, are abnormal mobility if there is no implant which is holding the fracture ends. It is associated with limb shortening or an obvious deformity. The investigations, basic investigation which we all do is the X-ray, which will show you sclerotic ends or necrotic bone as is seen in this picture. One can go for a CT scan or an MRI to understand the exact presence of any sequestrae or if the soft tissue involvement of the infection, if there is an abscess. A cyanogram will show us the source of the sinus from where it is tracking, if there is any sequestrum that can also be seen. And superficial wound cultures have a very limited role in the management of infected non-unions. So the various difficulties associated in management of infected non-unions are that these patients are usually multiply operated. So the soft tissue cover is suboptimal and the vascularity of the bone is also reduced due to either multiple surgeries or the presence of infection. There can be necrotic bone at the non-union site. These patients may be previously multiply operated, so the adjoining joints may be stiff. They have received loads and loads of antibiotics because the first reaction of any surgeon to tackle infection in this self-operated case or anyone's case is antibiotics. And the haphazard use or indiscriminate use can lead to severe antibiotic resistance. And the soft tissue envelope is also not as it is in a fresh fracture. There may be sinuses, there may be adherent skin due to previous plastic procedures or due to previous scarring of the surgeries. So the aims of infected non-union management in long bones can be broadly staged into infection control to establish bony stability, to encourage or enhance the union or the biological healing process of the bone, and to reconstruct the soft tissue envelope. So I'm going to briefly talk about how one can achieve all these aims. Coming to the classification of non-unions, ASAMI, that is the Association for Study of Applications and Methodology of ILIZAROV, has classified non-unions into A, B, C. A and B are the aseptic non-unions. So we are going to talk only about the C part, that is the infected non-unions. And further classifying the infected non-unions, there is a non-union severity score, which is from Leeds. Now, this is quite an exhaustive score. It can be compared to the mangled extremity severity score or the Ganga hospital score, which helps one decide whether to salvage a mangled or a badly fractured limb. And this applies to non-unions, while the MES score or Ganga score applies to fresh injuries. So there are various parameters that are taken into consideration while calculating the score. And to mention them briefly, one is the bone quality, which may be good, moderate, poor, or avascular or osteoporotic. Then the second factor is the primary injury. If it was a closed fracture or if it was a grade 1, 2, 3 Costello-Anderson compound fracture. The number of previous surgeries also having a role in deciding the outcomes during treating infected non-unions. The invasiveness of any previous surgery, whether it was a minimally or a sliding procedure, or it was an intramedullary nailing or a surface fixation. Then any bone grafting which has been done earlier is also into consideration. Then the Weber and Czech classification, which we saw in the first slide, whether it is a hypertrophic or an oligotrophic or atrophic kind of non-union. The bone alignment, whether it is anatomic or non-anatomic, if there is a bone defect or a gap. The soft tissue status, whether there is a previous scarring, or there is any plastic procedure such as skin grafting or a local rotation flap or a free flap, and the presence of a sinus or an ulcer or exposed implants. The general condition also is considered the ASA grade, the presence or absence of diabetes, then the presence of infection if it is in the active phase or if it is in the quiescent phase, associated drugs like steroids, NSAIDs, and whether the patient is a smoker or non-smoker. So the score totals to 100, and if the score is more than 75, then the surgeon should strongly consider going for amputation versus reconstruction, because even though we may have quite a few methodologies and techniques in our armamentarium, if the situation is beyond salvage, no matter how much we try, we will not succeed. Injury severity score is another score which helps in classifying infected non-union, that considers 6 points broadly, which is the presence of sinuses, the condition of the skin, the presence or absence of sequestrae, if there is active discharge from the sinus, if there is any implant which is present, and if there is any requirement of local antibiotic delivery system. So higher scores in injury severity score also indicate that there may be a need for a secondary procedure such as debridement for complete eradication of the infection, and a lower score might allow you to do a debridement and think about going in for internal fixation with minimal risk of subsequent infection. So the goals of treatment in an infected non-union, first is to eradicate infection. Unless we do that, we will not be able to achieve our second goal, which is to achieve union. And the third goal is to achieve the first two goals with minimum soft tissue problems such as deformity, joint stiffness, or limb length discrepancy. So the methods to eradicate infection, firstly, general methods to increase host resistance such as systemic antibiotics, local antibiotic delivery, and to optimize any pre-existing medical conditions such as regularize the blood sugar levels, advise or promote cessation of smoking. And the second part is to decrease the infection load, that is the local infection load. So that to achieve that, one has to do a thorough debridement, that is the mainstay of treatment of any infected non-union. Adequate irrigation and negative suction dressing such as wax can also have a role in eradicating the local infection. Then to achieve union, there are various methods one has to exercise, such as different types of bone grafts, and then the stabilization of the non-union or the bone ends. So the bone grafting can be, of course, done after the eradication of infection, and it can be either an onlay single or dual onlay bone graft, or it can be the traditional Papineau technique, which first involves the eradication of infection with skin cover and then bone grafting, or it can be a posterolateral graft such as the Harman's posterolateral graft. Of course, now we have newer techniques such as MASQUELET techniques, about which I will be talking later on. And the bony stabilization, particularly for infected non-unions, is focused on external fixation more often than internal fixation, because internal fixation has a higher than usual risk in an infected non-union. The presence of any internal implant will harbor the microorganisms and which can get reactivated on the lowering of the patient's immunity. So the operative techniques, the main and the most important step in the treatment of any infective non-union is a debridement in capitals. There is no two ways, or there is no escaping this step and it is the primary step in the management of any infected non-union. It involves radical removal of all dead and necrotic tissues. So like you can see in this figure here, this bone is all sclerotic and a major portion of the bone has been required to be excised until you reach bleeding or healthy bone ends. So that is the criteria to decide how much bone to resect, and sometimes you have to be ruthless, but unless you do that, the infection will not be eradicated, the union will not be achieved. So debridement or radical debridement is the key to success in the management of infected non-unions. And there is a lot of this fibrous tissue scarring in previously operated infected cases. So once the bone ends are freshened, then we have to excise all the fibrous tissue, because unless we achieve bone-to-bone contact by whatever method, it will not progress to union. Once this is done, we often find that the medullary canal is blocked and the bone ends are sclerotic. In that case, the next step is to make drill holes and achieve or re-establish the patency of the medullary canal. One can do that with multiple drill holes followed by using an awl and then hand reamers. So that is an equally important step to aid the biology or the even for the antibiotics to reach the site of the infected non-union. Once this is done, then we assess what is the defect that we are left with. If it is less than 5 centimeters, then one can consider a primary docking, that is a primary end-to-end contact of the two bone ends. If it is more than 5 centimeters, it is risky. It can cause kinking of the vessels. So we try to avoid primary docking if the bone defect is more than 5 centimeters. As is shown here, if we want to achieve primary docking, we need to do a fibular cuff resection. Only then will it be possible to approximate the tibia in good contact. Once that is done, we use cross K wires to temporarily stabilize the bone ends. Some surgeons prefer to use a 5 or 6 hole plate with 2 screws on each end. The advantage of doing this is that your reduction is stabilized temporarily. So once you put those cross K wires or a plate, then you can go ahead and complete the external fixator assembly or fixation without worrying about any displacement of the bone ends. Of course, goes without saying, after debridement, a thorough wash with either hydrogen peroxide, betadine, or normal saline is a must. If we achieve local docking end to end, then we do a shingling or a local osteoperiosteal flaps. In the presence of active infection, if we are treating it one stage, it may be risky to do cancellous bone grafting. So this is an alternative which we call local bone grafting. Once that is done, we do the skin closure and put on the fixator, and then in the end we do a corticotomy using multiple drill holes. So all these steps I will explain when I show you few of the cases. The ILIZAROV technique is one of the most commonly used techniques, especially for treatment of infected non-unions. It works on the principle of tension, stress, and distraction osteogenesis, which means there is mechanical induction of new bone formation and neovascularization. There is also stimulation of biosynthetic activity, which helps in intramembranous ossification and activation and recruitment of osteoprogenitor cells. So the distraction, the procedure is used to correct deformities and correct any shortening if it is present. So it has a dual advantage of achieving union, eradicating the infection, as well as correction of any limb length discrepancies. One can do a corticotomy usually in the metadiaphyseal area, proximal or distal of the bone, depending on the location of the non-union site. and controlled distraction is done at the corticotomy site at 1 millimeter per day. Either twice a day, 4 times a day is ideal, but may not be practical. And once we achieve the required length, then there is a consolidation phase in which the gap that we have created needs to develop, regenerate, and become strong enough for us to be able to remove the fixator. So I'll just come to a few cases and describe the techniques as well as we go through the cases. This was a 35-year-old female who had a segmental compound fracture, grade 3B tibia. You can see the combination. There is a proximal tibia fracture which has been fixed with a cannulated cancellous screw at the time of initial debridement and external fixation. This X-ray is after removal of external fixator, and there is non-union at the middle third level. So in this case, we have used a 3-ring construct along with a foot frame. We have done a fibular cuff resection here to allow acute docking or to allow compression, and we have done a distal corticotomy in the distal tibia. As you can see in the pre-operative X-ray, the limb length is maintained as the fibula has an undisplaced neck fracture but no bone loss. So the purpose of the corticotomy in this case is merely to enhance the biology and not to do any lengthening. So this is the immediate post-operative X-ray, and this is the final result at the end of 6 months. It appears to be in slight valgus, that is primarily because of the medial cortical defect rather than any alignment issues. And at 9 months, the patient is walking comfortably without any support. Another case, this was a grade 2 compound. It was a bifocal femur fracture. So initially, the wound was debrided under local anesthesia. Upper tibial pin traction was applied. Once the wound was found dry, then we went in for internal fixation with the help of a reconstruction kind of a nail. But unfortunately, the patient ended up with intramedullary infection. So, this case was done elsewhere. So he came to us with a discharging sinus from the distal femur fracture site. So first we removed the nail, we did a debridement, and we did an external fixator. And then in the second stage, we have done a ILIZAROV fixator for him. We use a hybrid kind of fixator for the femur in which there are shank pins in the proximal femur and Italian arches, and in the distal fragment there are 2 rings with wires. And this is the picture at 3 months post-op and at 9 months post-op. The neck fracture was undisplaced to begin with and not much infection there. So at stage 1 itself, we had removed the screws and it did not create any problem. As you can see, the neck is united and so is the shaft. Patient had some knee stiffness for which he was advised knee arthrolysis but did not come back. Another case, this is a common scenario, compound tibia comminuted, long segment comminution. So we went in and during the debridement, we realized that almost more than 1/3 of the segment of the tibia is sclerotic and sequestrated. So there was no option but to excise it, and then we were left with a large defect. So in this case, we have done what is called internal bone transport, where the fibula is left untouched, and we do a distal tibial corticotomy. And I use this technique of passing one ILIZAROV wire through the medial malleolus, which goes from the distal to proximal fragment. It just guides the fragment of bone which we are to transport along it so that there are no angular deformities during the bone transport. And this was at 3 months post-op when the distraction was complete. As you can see, the regenerate is hardly there, but there is docking at the non-union site. At this step, we do a second procedure which involves removal of any interposing soft tissues. Sometimes with such a long bone transport, the skin may get invaginated. So it is mandatory to excise that skin. And we use that opportunity to pack in cancellous grafts at the same time. Sometimes the skin condition may not be conducive to allow you iliac crest bone grafting. So in that case, I just use local osteoperiosteal flaps. And due to the corticotomy and the regenerate, it is quite surprising to see that even the cortical bone at the non-union sites is so hypervascular, almost feels like cancellous bone. So that suffices in case the skin does not permit you to take iliac crest bone grafts. So this was at 6 months post-op, and at 1 year post-op, you can see that the regenerate is well consolidated and the fracture is also united. So next case, again a compound tibia operated previously elsewhere with multiple KOIs which are serving no purpose towards stabilizing the bone except maybe devascularizing it. So again the same technique, excise all the necrotic bone, do a distal tibial corticotomy, do bone transport over an intramedullary wire. This is at the end of the bone transport. Then you do a bone grafting. In this case, iliac crest was used since there was an anterior cortical defect. And as you can see, the regenerate is consolidated and the fracture is united. This is the final picture at 1 year. Another common case, compound tibia fracture treated with an external fixator and skin grafting. This case, I remember the skin condition, there was a circumferential skin graft all around the distal tibia, which is anyways a hypovascular area. So this was after removal of the fixator, and we did a fibular cuff resection, we did a proximal tibial corticotomy, and these are the two cross KYs. This was one of the initial cases. So at that time, I used to keep those KYs since just to enhance the fracture stability. But nowadays, we just use it intra-op, and once the rings are put on and connected, then we remove the KYs. So 2 months again, you see one wire is loosened out, the other one is still there. And at 6 months, the fracture is united. Even the fibular cuff that was resected has regenerated. You can see the skin condition. The entire foot and ankle area is just skin graft. There's no soft tissue there. Another case, this was a person from out of state, initially treated with nailing, then got infected, debridement, plating, external fixator, came to us with a stiff kind of non-union. So the stress views are just demonstrating the abnormal mobility. And again, we went in and did all the before mentioned steps, freshening the bone ends, removing the fibrous tissue, reaming the bone ends, creating the medullary canal, and we put on an ILIZAROV fixator. This is at 3 months post-op, and at 6 months the fracture went on to heal. Because of his multiple previous procedures, you can see that the ankle is already fused. So these are some of the problems associated with infected non-unions that are previously multiply operated. And I don't know if this video will play. That's his gait. The knee is also not completely mobile. He just had about 60 degrees of knee range of motion. And the ankle, as you could see in the X-ray, is completely arthrodesed. But he is able to ambulate without support because the union achieved is good. So coming on to the femur now, this was a previously distal femur plating done in a compound fracture, which unfortunately got infected. The plate was removed, we debrided it, and we used the MASQUELET technique in this, which involves placing of a cement block to fill the defect, antibiotic impregnated cement block, and replating was done. But unfortunately, the infection could not be controlled. So when it was time to remove the cement block and put bone grafts, what we decided is to remove the plate and apply an ILIZAROV frame and then do bone grafting at the same time after a thorough debridement. So here we have removed the plate, we have done an ILIZAROV fixator, which is knee spanning. He also had shortening, so a tibial corticotomy was done to compensate that length. The knee was already stiff and unlikely to have movements due to the previous soft tissue scarring. I've used a fibula strut graft here. And since we did masculine technique, the biomembrane that forms over the cement block or the cement spacer, that you can see in the lower X-ray, the cancellous graft has already started hypertrophying and the fibula is also getting incorporated. Unfortunately, this patient was lost to follow-up, so I don't have any further X-rays, but this was just to demonstrate the masculine technique and how well it works, especially in the femur. Now, ILIZAROV for femur can be quite cumbersome for the patient. Compliance is an issue. The pins in the thigh keep bothering, keep getting infected. So limb reconstruction system is an alternative, which is a uniplanar fixator, and it has 6 tapered chance pins with clamps that are attached to a monorail, and the use of a compression distraction unit, which allows one to compress the non-union site and as well as lengthen at a corticotomy to correct the shortening or to enhance the biology. So this is just one of the many papers from the International Journal of Orthopaedic Sciences, which states that LRS is equally as good as ILIZAROV, especially in the treatment of infected non-unions. So this was a case of a compound femur fracture, again treated initially with an interlocking nail. Unfortunately, got infected, so the nail had to be removed, and we did an LRS here. So these, you can see the CD unit that is connected to the clamps across the non-union site, and it was used to compress the fracture. The bone end was hypovascular, so after 3 months I had to do bone grafting for this patient since the union was not progressing. And it went on to unite. It looked slightly deformed because of the medial cortex defect. There is some element of varus as well. The patient was able to walk. Another case, now this case you can see previously nailic done, infected. Bone ends are completely sclerotic, necrotic. That bone will never heal no matter what you do. So you're left with no option but to excise it, and then you're left with a big defect. So to cover the defect, we did a distal femoral corticotomy and a bone transport with the help of the CD units. This is showing the bone transport in progress. And once we achieve the docking, then again we go down, remove all the interposed fibrous tissue and do an iliac crest bone grafting. So that was at the end of 1 year, where the fracture is united and the regenerate is also consolidated. So post-operative antibiotic cement rods is another modality that we can use. If there is fulminant intramedullary infection, then even the fixator pins are at risk of loosening out. So a staged surgery is advocated in such situations. The stage 1 is to use an antibiotic impregnated rod, which will act as a local antibiotic delivery system and help in controlling the infection. And once that is achieved, then go in for definitive fixation for bony healing. Like we saw, the aims first is to eradicate infection. So this is the step towards eradicating infection. But sometimes one can get lucky, and the same single procedure can also give you union. So the advantages of an antibiotic impregnated cement rod is the local antibiotic delivery is 200 times higher concentration than any IV antibiotic. And the various antibiotics which can be used with cement are the heat-stable antibiotics commonly used are gentamicin, vancomycin, cefuroxime, and teicoplanin. So we prepare the antibiotic-coated nail on the operation theatre table. We use a 8 or 9 millimeter K nail. We use 20 grams of cement. For 20 grams, we mix about 1.5 to 3 grams of cefuroxime most commonly, or about 80 milligrams of, 2 grams of vancomycin or 80 milligrams of gentamicin. And the nail is prepared by coating the cement. A nail of diameter 8 or 9 millimeter, once it is coated, can become as thick as 13 millimeters, which may not fit in the medullary canal. So we downsize it, and this instrument shown, the rectangular one, is a K-nail sizer, which has different diameter sizings. So we size the coated nail to 12 millimeters. We ream the canal to 13 millimeters, and that accommodates a nail, because the nail, if it is too thick, it can get jammed and cause problems on table. It will neither go in nor come out. So sizing of the nail is a very important step while doing this procedure. So this is a case, again, a comminuted femur fracture operated somewhere with open interlock nailing and ensucklage wiring, which got infected. So we removed the intramedullary infection. So we removed the nail, reamed the canal to 13 millimeters, inserted a 9 millimeter nail with antibiotic cement coating. And as you can see, luckily for us in this case, the fracture united with just this procedure. This is 1 year post-op with the same nail. And that's the function of the patient. Another case, this was done somewhere else. It was fixed with a short reconstruction nail, which was bound to fail for this fracture anatomy. And plus it was an open nailing. So we removed this and we put in an antibiotic cement nail. But the subtrochanteric level, the nail was also not completely adequate for achieving union. So as you can see, the nail has backed out and it has broken as well at the fracture site. But luckily, the local antibiotic delivery served its purpose or function of controlling the infection. So we just had to remove this nail and go in and do another nail and bone grafting. Unfortunately, again, I don't have the final union images of this patient. This is one more case of intramedullary nailing got infected. It was treated with a LRS, and this was a static frame, went on to unite, and that's the final X-ray. So post-operatively, antibiotics are essential and adjuvant for controlling the infection, and it is advisable to involve an infectious disease specialist to decide the antibiotic protocol post-operatively, which antibiotic as per the deep cultures taken during surgery, and depending on the organism, sensitivity, duration of the antibiotic. I usually IV antibiotics may be advocated for a longer period, but practically there are limitations. So I try to at least give 2 weeks of IV antibiotics followed by 4 weeks of oral antibiotics as per the culture sensitivity. And this is a paper which shows that 6 weeks is the antibiotic therapy recommended. And of course, if you use local antibiotic delivery like a MASQUELET or an intramedullary antibiotic cement rod, then you can reduce the duration of systemic antibiotics. The complications of infected non-unions. One is recurrence of infection, main cause maybe inadequate debridement, or like we saw in the classification, if the non-union severity score is high, then we are in a position to predict whether a repeat debridement is warranted in a case. There can be persistent non-union. In spite of our best efforts, there are 8 to 10% non-union rates of in management of any infected non-union. So that is, and that can be either biological or a mechanical failure, which may warrant a repeat surgery. There may be a deformity in case you're doing a lenning at the corticotomy or the regenerate site or at the non-union site as well. Limb length discrepancy, neurovascular deficit, stiffness of knee, stiffness of ankle, foot drop. These are all the common complications associated with infected non-unions. There can be problems with the regenerate as well, like I said. The wires, if they are not of the ILIZAROV frame, if they are not tensioned adequately, they may loosen out and it may cause angulation or poor regenerate formation due to lack of stability of the frame, and general systemic causes as discussed earlier, as well as local causes such as soft tissue problems. But usually if the frame is stable and the construct is adequately stable, regenerate problems are unlikely in spite of the poor skin condition, and that is one major advantage of the ILIZAROV technique. So in case the regenerate is poor, like we saw in the previous cases, there was a huge defect and that may take months on end. If you want to hasten the regenerate, then one can use either the accordion maneuver, which is alternate compression and distraction at the regenerate side. Check the tension of the wires. In few cases, I have used iliac crest bone marrow aspirate concentrate. Use a PRP machine and use the bone marrow concentrate, just inject it in the regenerate, and I've found that it works in helping in consolidation of the regenerate. Teriparatide injection is another thing that helps in faster consolidation of the regenerate. So as we discussed, MASQUELET technique is advocated for infected non-unions. It's a two-stage approach in which stage one is a radical debridement and an antibiotic cement spacer inserted in the bone defect, and the spacer functions dually. It gives mechanical support to the by filling the defect or the gap between the bone ends, and it also, more importantly, has a biological effect of a formation of a biofilm around the spacer within a duration of about 8 to 12 weeks. So this biofilm, it is supposed to be resistant to infection as it is impervious, and it also functions somewhat like a periosteum, the cambium layer, and enhances osteosynthesis or the osteogenic potential of the bone grafts. So this shows how in the second stage the spacer is extracted at about 6 to 12 weeks depending on the control of infection. Any antibiotic cement elutes antibiotic for a duration of 12 weeks, so that is taken as the limit for the functioning of that antibiotic cement. So at the end of 6 to 12 weeks, we remove the cement. You can see the biomembrane, and then we pack it with, depending on the size of the graft, like I showed in the case, a fibula strut along with cancellous iliac crest graft or just cancellous iliac crest grafts. So to conclude, a tailor-made strategy is required for management of infected non-unions, and it's not one size fits all. It depends on various factors, the patient factors, the fracture, morphology, location, as well as the extent of the severity of the infection. There is no two ways that radical and thorough debridement is the mainstay of management of infected non-unions. There is no way one can skip this step and achieve a good result while treating these situations. Compression at the non-union site plus lengthening or bone transport is the advantage with circular or monoplanar fixator systems. And bone grafting augmentation after the eradication of infection should be considered while managing these. Masculate technique, as I showed, and antibiotic cement rod also have their place for local antibiotic delivery to control the infections. And like we saw in all the cases, ILIZAROV or LRS, depending on your choice or the type of injury, gives good results in the management of infected non-unions. I would like to thank you all for a patient hearing, and I would be happy to take any questions if there are any.
Hi Chetan, that was a very comprehensive cover of infected non-unions. I feel I have many questions. I have done cases with you before, but that has been many ages back. So as the MASQUELET technique and infected non-union treatment with the rods have come up, is your use of ILIZAROV reduced?
Since I have been using it before MASQUELET or before antibiotic rods, no. But like I said, if there is a possibility of going in for second stage internal fixation is one primary indication for going in for either of the techniques. Second situation is if there is fulminant intramedullary infection where I feel there is a risk of my pins loosening, or those are the situations I will do a staged procedure.
Okay. And the MASQUELET technique, have you used in tibia also or mainly in femur?
I have not used it in tibia, but literature says that the results are better for femur than tibia because of the soft tissue cover.
Okay. And how do you do this? Have you see in our case, which we did few years back, that patient had when you do these long, especially when there is a long gap, and when you start docking from both the sides, means the osteotomy has both the sides, corticotomy, and then bone transport is distal to proximal and proximal to distal. So there is usually a flap in the middle or a skin, whatever it is. So that is it by rule that it always goes and dips in the middle, or is there a way to prevent it?
90%, if not 99% of the times, even if the skin does not dip in, there is fibrous tissue when that gap closes, which is covering the bone ends. So in original ILIZAROV philosophy, they used to keep the rings for months and months, and their theory was that fibrous tissue converts into osseous tissue. But if we are in a hurry, then what we do is we open the non-union site once we have got the bone ends in place. If there is skin that has gone in, we can excise that. There is invariably fibrous tissue which we excise. Again, I make the canal patent if it is obliterated. And then I assess the skin condition to decide whether it is going to allow me to place cancellous grafts there. Otherwise, I just do local shingling, OP flaps, pack the non-union site and close the wound. But I do this once docking is achieved invariably.
Okay. And what is the role of culture in this? Do you stop antibiotics 2-3 days before you take the patient for surgery and then take the culture, or do you still has the patient?
Ideally, yes, but logistically not possible because the patient usually gets admitted 1 day prior to surgery. But recommendation is that should be stopped 72 hours. Antibiotics should be stopped 72 hours prior to culture.
Okay. And you were talking about deep cultures. Do you take it before the debridement or after the debridement?
During the debridement. As soon as I reach the bone, if there is pus, then I take a swab from the bone. If there is granulation, it is usually on the bone or surrounding the sequestrated bone.
So once you have cleaned and everything and given a wash, you don't take any cultures later on?
No.
That is not recommended. And
if debridement is good, then it's unlikely to grow anything.
So you showed a lot of cases of bone transport using the LRS type of fixator in the femur. Have you used in tibia also?
Yes, like I said, there is 8 to 10% chance of failure in spite of our best attempt. So in case I've done ILIZAROV for the tibia and it is still not united, then the patient compliance is not there. That is when I have done it. Or if the patient is really has undergone ILIZAROV earlier, they are not psychologically ready to undergo the same procedure. So that is my prime indication for LRS in tibia.
And when the patient comes to you with an infected non-union, do you do the debridement and the final ILIZAROV on the same sitting?
More often than not, yes.
What about the corticotomy?
I do it in the same sitting.
So I had heard many years back that corticotomy actually causes a vascular rush in the whole limb. And sometimes basically it enhances it actually reduces the chances of reinfection.
Definitely, because it improves the vascularity. That's what I was saying. Like when I open after docking to do the removal of fibrous tissue, more often than not, iliac crest is not required. The local bone is so hypervascular, it functions as a cancellous graft in spite of being cortical bone. And that is another reason why wound healing is also not a problem. The skin is terrible in most of the tibia cases especially. So even if you, after doing this bone grafting procedure, you don't get 100% closure, you just have to continue with dressings and the wound heals within 2 to 3 weeks at the most.
Okay. And do you need a plastic surgeon in that case where you do bone grafting at the second stage? Do you involve a plastic surgeon regularly?
No, I involve the plastic surgeon only for primary external fixator. I mean, not for non-union management.
Okay.
Even if
later on when you have to open and do the bone graft of the flap and everything.
Like I said, it's never, because of the hypervascularity, wound healing has never been a problem. So I've not involved a plastic surgeon.
So in your hand, the MASQUELET technique in the distal femur or the middle femur has found a lot of success, you would say, and has reduced LRS?
No, my first choice is still LRS.
Okay.
Because I don't have adequate experience with MASQUELET to give me that confidence, just about half a dozen cases. But those cases, we saw that it works. You can, when you go in for the second stage to remove the spacer, you can distinctly identify that membrane.
And this use of stimulant, how frequently do you do it?
Personally, for cost reasons more than any scientific reasons, I'm little hesitant or reluctant. So I have very limited experience with not just stimulant, any synthetic bone substitute.
And these grossly infected cases, badly done, they're badly complicated. Usually, though they start walking and they become all right, the fracture heals and everything, but they always have the adjacent joint stiffness. The ankle is never normal.
Yes.
The knees are never normal.
Preliminary assessment should take into consideration all these factors that are going to be there, part and parcel of the non-union. And your ILIZAROV will heal the fracture, eradicate infection. It cannot make the stiff joint mobile.
So have you undergone, has any of these patients in the last 15-20 years come back to you for arthrodesis of the ankle?
Bone transport arthrodesis?
Means later on, means basically they are so stiff and so uncomfortable that their ankle is painful, or they're just so badly, so they are just finished with the surgeries, they don't want to undergo any more surgery. Is it like that?
No. Arthrodesis is for ankle, yes, a couple of times. In one case, I showed it fused spontaneously.
Yes.
More than that, in femur, when you do a bone transport, knee stiffness is a bigger issue. So that may require a knee arthrolysis or a quadriceps plasty, a Jude's kind of procedure for improvement of motion.
So what happens is that these patients have already undergone so many surgeries that are they willing to do another surgery just to get the range back?
That is the challenge. So before embarking on management dialogue, and whether to put the option of amputation on the table in front of him, because Ganga Hospital says any fracture which is not healed for 18 months is an indication for amputation. Some of these ILIZAROV bone transport treatments last for 18 months. So that option one should always put forth is what I feel, especially when the treatment duration is going to be so long. The limb is not going to be functional as the opposite normal limb. And thirdly, the repeat procedures in case the infection is not controlled in one surgery.
And the amount spent per surgery, they can get the same amount in that same amount with a very good processes where they can actually run.
Absolutely, but that is, having said that, it's a very personal choice. It is up to the surgeon to offer that choice, but 90% of the times the patient will not agree. He is willing psychologically to accept a suboptimally functional limb. It's only when there is a long-standing foot drop with a fixed equinus. At that time, even if you achieve tibia union, that is not going to correct. And at the most, you can make him plantigrade, but it by a fusion.
Right.
So those cases, amputation is viable and can be a primary option.
Okay, so besides this, to avoid infected non-union and compound grade 3B or grade 3A fractures, have you used primary ILIZAROV?
Very rarely. I am a reluctant ILIZAROV surgeon, so to say. A lot of ILIZAROV surgeons will ban me for not using primary ILIZAROV. But I feel if the compound wound warrants a plastic procedure, I'm better off doing normal AO type external fixator, allowing the soft tissues to heal, and then change it to an ILIZAROV fixator once the skin cover is good.
Sometimes even a nail if the wound and everything
absolutely,
is fine.
Absolutely. If it was my leg, I will prefer a nail over ILIZAROV any day.
So do you use proximal in the comminuted proximal tibia and ILIZAROV?
Rarely, but now with all the new locking plates, even that indication, it's basically about patient compliance. The internal fixation, if it is uncomplicated and goes well, is so much more comfortable for the surgeon and patient vis-a-vis an ILIZAROV.
So I have seen now surgeons doing, even one of my friends who works with me sometimes he likes to put 4 plates in the proximal tibia and 3 plates in the tibia and 1 plate in the fibula.
Yeah, I have used 3 quite often, 4 just once.
So where earlier you would have used a ILIZAROV, but because of these good plates, now you are using a
no, I have not used ILIZAROV as much as an ILIZAROV surgeon uses it for acute situations.
Okay. Okay. Thank you very much, Ashok.
Okay.
I just checked the website. Also, there are no more questions. Do you have any questions on your WhatsApp?